her bigger than she is, so.
How many, you have 8 children, right? How many boys and how many girls?
5 boys and 3 girls.
Okay, so you've got that big boy thing down.
All right, we're here with Margie Tua, and tell me one more time your name.
Anna Lynn.
Anna Lynn, and Dr. Juliash and Rachel, and we're talking about your upcoming transplant. So the first thing we need to tell you is that you're in remission after working hard with 2 induction cycles. So that's very, very good news.
Mm-hmm.
So if you're in remission, why are we here talking about a transplant might be the next question somebody would think about. So we know that when you are in your 60s with AML, it has a pretty good chance of coming back if treated with chemotherapy. And we know that there was something in your chromosome changes that happened to your leukemia, the deletion 7. Do you remember talking about that?
I remember hearing something about that.
That's just a marker of a kind of aggressive behavior. But this aggressive behavior can be overcome by a transplant. So that's why we are recommending doing a transplant in first complete remission. We say a transplant in CR1, first complete remission, as your best way to consolidate this remission. And what we mean by that is there's probably leukemia cells in your body. We didn't see them in your bone marrow, but they must be there. And if you stopped all treatment, it would come back in a month or 6 months or by a year. If we gave you 4 cycles of consolidation chemotherapy, maybe it would come back in 2 or 3 years. So the best way to try to kill these residual leukemia cells that we can't even see is with a transplant that does 2 things. One is it allows us to give you more chemotherapy that might do a better job killing those residual cancer cells, microscopic cancer cells, but maybe that chemotherapy would be too toxic to you, to your own bone marrow cells. But your sister's cells can rescue you from that. So that's one part of it, is being able to give you more cytotoxic chemotherapy. But the other part of it is that your sister's immune cells will do a better job than your own body cells at recognizing these cancer cells and killing them by a graft versus leukemia effect. So we think you're actually in the best situation because you're so healthy. You're like one of the healthiest people that I know. And because you're in remission, that this is actually a good circumstance to have the transplant. So let's just review your workup. I kind of have it here summarized a little bit. So you had a bone marrow on the 11th, and we didn't see any leukemia cells there, and your chromosomes were now normal, where before they had this, it was kind of a complicated isochromosome with loss of chromosome 7. So we don't see that now, which is very good. Your blood counts, the last time we did them were good, but I'm waiting for today's to comment. But on the 23rd, your neutrophil count, your red cells, your platelets were all good, and all your chemistries were good too. But before we're done today, we'll just make sure that's still the case.
We're expecting them to be good. We're not expecting any surprises. You never know until you know, but we're expecting them to be just fine.
Hey, has anything happened to you that I need to know about since you were here on the 23rd?
No.
You feel good? Good. And you're having some sort of family reunion this weekend?
Yes.
You're gonna eat a lot of things that normally you'd be like, oh, my diet, you know, I can't really munch on all this stuff, but you're gonna pig out at your 4th of July party?
Well, we have semi-healthy foods.
Oh, okay. Well,
you can have the unhealthy, the healthy, or the semi-healthy. Don't hold back.
You can
You can have it.
Load up.
Well, I have gained weight since I've been home. So.
But that's all right. If it's good weight, right? Good protein weight, help you heal better from this. So we did some coagulation studies, but one of the numbers was not that good because I think they drew it from your line and there was heparin in it. So today I'm double checking that lab too.
That's why they stuck you. Sorry about that.
Right, because whenever we try to get away with getting it from the line, I'd say half the time it comes back not normal because of the heparin. So you are O positive and you have not developed any antibodies to red cell or platelet antigens, which is good. It means it's, you know, easy to transfuse you when you need it. And your sister is A negative. So eventually you're going to be A negative. You're going to switch over blood types. So if you leave your blood at the scene of the crime, they'll blame your sister.
Oh, my brother threatened to do that.
Ah. But the thing.
Now it won't be traceable back to you.
Oh, that's true. I'll have to tell him that.
Right. So the thing is that you have anti-A in your blood, antibody, and your sister has A. Now when we get her peripheral blood stem cells, it's not going to have a lot of red cells in there, so we'll give you some medications so that you don't have a transfusion reaction. But when eventually, a couple of months down the road, every time you make an A cell, your own anti-A might bind to it until your lymphocytes that are making anti-A learn not to do that anymore. So because of this, you might end up with some more transfusions than if you didn't have that different blood type. And also, you wonder whether there's any interaction for graft versus host disease due to the ABO. So that's a little bit of a glitch, but usually people get through it with no problem. If you haven't had a lot of transfusions, but if you have more than 20 transfusions, you keep the iron in you, and sometimes too much iron in your body can affect your organ functions, like your endocrine organs or your liver or your heart. So in the end of this whole thing, if you've had too many transfusions and your counts are now good, we might want to take some blood out of you to prevent iron overload.
That's a ways down the road.
Yeah. So we do.
Oh, and just this blood type, when you become your sister's blood type, it's not generally something that happens overnight. It's sort of a conversion process.
When you're at your 100 day, we can look into seeing if that happened already. Sometimes it happens after day 100. So we did an infectious disease workup that we have to do by law on you and your donor, looking for hepatitis and HIV and West Nile virus and African sleeping sickness and all sorts of things, syphilis, and all of that was negative, except for past exposure to a very common virus called CMV, cytomegalovirus. So that might have been a cold that you had at some point in your life. It's pretty common, like more than 50% of people have seen that virus. During the transplant, when you're immunocompromised, that virus can activate. Very similar to chickenpox coming out and being shingles. So we worry about CMV reactivation and CMV infection. And so we're going to do a blood test throughout your post-transplant time, looking for the PCR test for the virus, because we just tested your antibody. You have protective antibodies. But when you're on immunosuppressive therapy, if that virus gets active, it can cause diarrhea, it could cause pneumonia, it could cause eye infection. So we're going to be on the lookout for that. We're going to give you acyclovir, which you're on, right? But that might not be strong enough to prevent it from coming out. So sometimes we have to bring out the bigger guns, a drug called ganciclovir or foscarnet. So that'll always be something that we'll monitor for. The other thing is that your antibodies that you make to protect yourself are all really normal now, IgG, IgA, IgM levels. But we're going to check your IgG level throughout, and if it gets too low, we can give you a product called IVIG to boost up your immune system to help you fight infections.
So what is the IgG?
It's like antibodies that your body makes to fight all different sorts of infections. But the immunosuppressive drugs can prevent you from making that. Right now your IgG level is 1318, which is great. We would replace you if it was less than 400. Okay, what else? Your thyroid. Okay, when we met you, we were you were on like a third of a 50 microgram of thyroid medicine. We didn't really know how to dose you, so we gave you a dose of 25 micrograms. So it turns out your T4 is good, but your TSH from your brain is a little high, so your body's working kind of hard. So what I'm going to do, and we can wait till you're admitted, is I'm going to increase your dose of the thyroid medicine to 37.5, so a 25 and a half of a 25, and then we'll check that again at day 100. Like we kind of guesstimated what you needed, and I think you needed like somewhere between 25 and 50. And then your vitamin D level is very good. And your other hormones are postmenopausal, but I guess that's not a surprise, right? No. Okay, your heart looks great. The echocardiogram talked about mild diastolic dysfunction, like all our patients have that, but I'm not sure if that's significant or not, but it's not concerning like your EKG and your echo are good for the transplant. Your pulmonary function tests, there's 2 parts of it, and for some reason only one part got done. So we just have to get the other part later this afternoon. The other part is whether there's obstruction getting air in and out. So we just have to do that part. The part we got was getting oxygen from your airways into your blood across the membrane. And that was a little decreased at 68% are predicted. Again, not concerning for this transplant, but, and I'm not sure why it's that way. Like, were you a smoker ever? I don't think so. So did you have pneumonia ever? Yeah, I'm not sure why, but it's just what you come to the plate with. So it's a little below normal, but not concerning enough. And we'll keep an eye on that in future tests.
And we have lots of people who are at that level.
Yeah.
So that's not an unusual thing for us to see.
And then your chest x-ray, you did actually have some sort of thing going on during induction in your chest, right? Some x-ray that showed maybe some infection. So that could be related to that. But anyway, all of that's improved. There's just like a little linear scar tissue, so that x-ray looked good. And then your dentist said you're okay to go?
I'm assuming.
We didn't get that report yet.
I haven't seen their official written report yet, but I'm sure they'll send
Yeah, because I had no cavities or anything, so.
that's what we like to hear.
And your sister's your donor, and Dr. Mitchell gave her own little time to make sure that was okay and everything's good there. We could get cells from the donor by taking them to the operating room and going under anesthesia and taking bone marrow out of their back. Or we can give the donor the drug to stimulate their stem cells to go into their blood and collect it that way. So that's what we want to do, because that helps you recover faster, your counts, and it provides a better graft versus leukemia effect, which is better for treating leukemia. The downside is that it could be associated with more chronic graft versus host disease, and that's something that we're gonna have to, be on the lookout for and possibly treat. But when we weigh the risks and benefits, it's worth it to do it that way because the benefits, I think, outweigh the risks. The benefit to hopefully having this leukemia never come back. All right, so all of that workup, minus today's labs that we'll peek at, makes you an excellent candidate for this. And so, yes, we'll give out some roadmaps now with the battle plan.
And this is something that you can write on if you want to. This is yours to keep. It's kind of a little bit about you, a little bit about your donor, and the things we want to do in the immediate future.
Here, I'll peek at one so I can translate it. So we're saying that you are in first complete remission here. We're saying that your disease risk index is high, and what I mean by that is because of your chromosome finding, you are more likely to relapse without a transplant. So that's why that falls into that category. This is, it's called a comorbidity index, and you get points for different things, like if your kidneys aren't good or your liver. And so it turns out if your DLCO is between 66 and 80, you get 2 points for that. So that's the only reason you get a 2 here. But I personally think you're one of the healthiest people that I've seen lately. So, but that just helps us in figuring out like where people fit and how they're gonna do. Then we have your blood type and the fact that you had CMV reactivity, and the fact that you don't have any antibodies to platelet antigens or HLA antigens is good. And then we always check your stool to see if it has this bacteria in it, and it didn't before, but that'll be an ongoing thing. And then this is your sister, Joan, and she is A negative, and she's never been exposed to CMV, and she's a match at all the antigens that we looked at. And we're gonna use peripheral blood stem cells on her rather than bone marrow. So this is your battle plan here. We're gonna give you 2 drugs, busulfan and fludarabine, for the transplant. Busulfan is the worker to kill residual leukemia cells, and fludarabine is an immunosuppressive drug that blocks your immune system from rejecting the donor. So the 2 kind of work together. What we've learned, actually doing this kind of transplant on someone in their 60s was always considered very dangerous, and it would never have been done in the past. But over the last decade, we've learned ways to make this really safe. And one of the ways is, it used to be given by mouth, but that was